Grand Rounds. My name is Katie Politi, and I'm delighted to introduce today's speaker. Before I introduce today's speaker, I'd just like to highlight this slide, which shows a Yale Cancer Center trainee survey. So if any of you are trainees in the audience and would like to complete this survey, there's also the opportunity then to apply for a new Yale Cancer Center trainee membership, which is really exciting. And then you'll be on a list so that you hear about all of the Cancer Center events as well and know other ways, can find out about other ways in which to participate. So I'd encourage everybody to do this who's a trainee. And I think there's also, you can win Yale swag or gift cards. So there's an incentive to do this as well if you're a trainee. All right. So I'm really, really happy to introduce today's speaker, Dr. Ann Chiang. Dr. Chiang is an associate professor of medicine in the section of medical oncology. She specializes in thoracic oncology with a background in translational research in metastasis and extensive experience in clinical practice in the academic setting and community settings. So Dr. Chiang received her PhD at Harvard University and then her medical degree at Cornell. She completed both internship and residency training at New York Presbyterian Hospital, Columbia Medical Center, and her fellowship at Memorial Sloan Kettering Cancer Center in New York. She then practiced in Connecticut in private practice, and then came to Yale, which it's been amazing to have her here. She's also an associate cancer center director for clinical initiatives here at the Yale Cancer Center. And for those of you who know Dr. Chiang, her clinical focus and her research focus has really been on small cell lung cancer and has really worked to develop a small cell lung cancer program here at the Yale Cancer Center, working with clinical trials, translational research, and basic research, and really bringing together investigators to do this. She runs clinical trials that are focused on testing new therapies for patients with small cell lung cancer. And really her interest is in bringing these studies from the laboratory, from all of the studies that are being done into the clinic. I'm especially happy to introduce Dr. Chiang. She and I have known each other since both of us were at Sloan Kettering a long time ago now. And I remember just being thrilled to find out that she was coming to Yale when she came to Yale in 2011. And feel so lucky to have a wonderful colleague and a friend right around the corner on the same floor, have our offices nearby. And she's a fantastic investigator, fantastic to have her at Yale. So really excited to hear her talk today. Thank you.
Thank you, Katie. Okay, let's see. Okay, great. Thanks for everybody for coming and for the invitation from the organizers to talk about small cell lung cancer, updates, progress, and the promise of targeted therapy, which up till now has really been in the realm of non-small cell. So we're going to talk about targeted therapy for small cell. Okay, let's see. These are my disclosures. These are the objectives. And this is kind of the overview. I'm going to spend some time on small cell lung cancer background. Then I'm going to talk about more clinical aspects, the therapeutics, the trials that we've been involved in the era of immunotherapy. And I'm really going to try to show you how the paradigm is changing in terms of small cell lung cancer and how several different approaches towards improving long-term outcomes. Then I'm going to move into more translational research and talk about targeted approaches for small cell, including bispecifics, antibody drug conjugates, and a new biomarker trial that's just activated. And then finally end with some IITs that we've been involved in. Okay, so some background. Small cell lung cancer is about 10 to 15% of all lung cancer. In 2024, there were about 16,000 cases diagnosed in the US. The average age is around 69 years, and about 95% of patients do have a history of tobacco smoking. It's a highly aggressive neuroendocrine tumor, about 70%, and that's on the right side here, of patients present with extensive stage small cell lung cancer. That means that they have cancer spread to a distant lymph node or other organs in the body. And then about 30% have limited stage where the cancer is really confined to one lung and local lymph nodes where radiation the disease can fit in one radiation portal. Okay, so for these 6 decades, the milestones were far and few between, with five red arrows. EP is the platinum doublet standard of care that was approved in 1990. And then there's some radiation advances in the 2000s, which I'm not going to focus on today. But the landscape is really changing now. And that's really with immunotherapy and our understandings and advances in our understanding of small cell lung cancer biology. So we are currently in the era of immunotherapy or IO. The red trials are basically the trials I'm going to cover. These have all been advances led to FDA approval, 5 of them in the past 5 years. So really the pace has really changed, and that's really due to immunotherapy. Okay, let's start with a case. I'm a clinician first and foremost, and this is really the North Star for why we do our clinical research and also our translational research is to help patients. So this is my patient, and we're going to talk about curative intent for small cell. 72-year-old woman with a prior medical history of hypertension and hyperlipidemia. She has a significant smoking history, and she presented with shortness of breath, chest pain, and a cough. And her chest x-ray showed a large right upper lung mass. In the PET scan, which is shown here, you can see FDG avid right upper lobe lung mass. She has bulky mediastinal lymphadenopathy, a right hilar lymph node, a right supraclavicular lymph node, but that can all fit into one radiation portal, okay? So she had an endobronchial ultrasound and biopsy, and that showed small cell, positive for neuroendocrine markers synaptophysin and chromogranin. And the Ki-67 is a proliferative index. That shows you underneath the microscope how many of the cells are actively dividing and in mitosis, in this case, 100%. So very active tumor. Her MRI of the brain was negative to complete staging. You can see a little bit of fluid there. That fluid was sampled and negative for malignancy. So her diagnosis is limited stage small cell lung cancer, and her treatment was cisplatin etoposide plus concurrent definitive radiation, followed by durvalumab, which is an anti-PD-L1 therapy for 2 years. That's the Adriatic regimen that I'm going to talk about. These are the immunotherapy trials in limited stage. I put a box around the Adriatic trial, which I'm going to talk about, and the NRG-LU005 trial, which I am not going to talk about. That was with atezolizumab concurrent with the chemo RT, and then followed by consolidation atezolizumab. That was a negative trial. So we can talk a little bit about that afterwards, but I'm going to focus on the Adriatic trial, which significantly was a positive trial, and it led to approval in 2024. So here's the trial, Adriatic. We participated in it here at Yale. It's a phase 3 randomized double-blind placebo-controlled trial. And in this trial, the patients who had already been treated with induction chemo, or not induction, but definitive chemo RT, and who had a response or no progression, were randomized to durvalumab for 2 years, placebo for 2 years, or durva plus tremelimumab, which is an anti-CTLA antibody. And I'm not going to talk about that arm. Those results aren't really back yet. So for the durva versus placebo arm, the dual primary endpoints were OS and PFS. And the Kaplan-Meier curves are shown here, both showing positive effect. And I think It's pretty amazing that the median overall survival here is in the Durva arm, that's in blue, was 55.9 months versus 33.4 for placebo. So it's not often that you can talk to a small cell patient about almost a 2-year benefit in overall survival. So this is currently the standard of care. You can see out at about 5 years, that's at 60 here, 60 months, about half the patients are alive. So we need to be able to extend this benefit to more patients, and that's sort of a theme that I'll be going over how to augment immunotherapy. So how can we augment the effects of immunotherapy? Will the addition of anti-CTLA-4 or other agents improve benefit? Does the addition of chemo post-progression to immunotherapy work? So some of these patients are on durvalumab and they have progression. Can we just add chemo back to that? We don't know the answer to that question in small cell or in non-small cell. In non-small cell, there's a large trial that I'm co-chair on of 600 patients intended to answer that question, among others. And that will result out in the next, probably in the next year, but I'm not going to go into that here. It's all focused on small cell. Can we use circulating tumor DNA to identify high-risk patients to treat accordingly? That means, can we escalate therapy if they're ctDNA positive, or can we de-escalate if they've cleared their ctDNA? And there's a lot of work in this area. I've shown you here on the right one panel, or the one figure that shows you that we helped to lead a real world trial where we did sampling pre and then sometime on treatment, and what you can see in the orange is patients where they cleared their circulating tumor DNA, and they certainly did better than the patients that didn't. But I'm not going to go into detail there. Okay. So back to another case of mine, another patient of mine. And in this case, the patient has extensive stage disease, and the aim is palliative intent. So she's an 82-year-old African American woman with a 40-pack year tobacco history. And she presented right around the time of COVID with weight loss over several months, worsening shortness of breath on exertion. And the PET scan here, again, shows you a very FDG avid right lower lobe mass. You can see a satellite lesion. She also had extensive regional lymph node involvement in the mediastinal and the axillary lymph node. So this is now a distant lymph node, very similar to the other, but because of the axillary lymph node, she was unable to undergo radiation, definitive radiation. Her brain MRI was negative, and then the biopsy also showed small cell carcinoma positive for the neuroendocrine marker synaptophysin. Again, very high proliferative index, 90%. So her diagnosis is extensive stage small cell, and her treatment was systemic. She got carboplatin etoposide, that platinum doublet, gold standard, plus immunotherapy, in this case anti-PD-L1, atezolizumab, followed by atezolizumab maintenance, and that's the Empower 133 regimen. And she got that until 2023. So 3 years later, we decided to stop that because she got COVID, not because she progressed. And so even 3 years from when she stopped, now she's 6 years out from diagnosis. Her recent scans showed no sign of disease. So I would argue in her case that even though it was palliative intent, I think she's cured from her small cell lung cancer. So really the paradigms are shifting here. Here is the regimen that she got on the left. That's the Empower 133 platinum doublet plus or minus atezolizumab. And this was approved because of a 2-month benefit in overall survival. So median overall survival, 12.3 versus 10.3. This was approved in March of 2019. And a very similar trial, the Caspian trial, used durvalumab instead of atezolizumab, and that also showed a benefit of around 3 months, 13 months versus 10.3, and that was also approved for first-line treatment. So these are our two first-line go-tos. This is the extended 5-year overall survival or long-term survival. Again, on the left, it's Empower 133. Those patients rolled over into an extension trial called Umbrella A. And even though there are very few patients, there's only 11 patients, the 5-year overall survival for that was about 12%. So again, some of the patients see that tail of the curve really improving or doing well. I think my patient's right over there at six years. But how can we extend that benefit to more than 10% of the patients? On the right side, that's the 3-year updated overall survival for the Caspian trial with durvalumab added to the platinum doublet. And the 3-year overall survival is about 18% versus 6% for the chemotherapy arm. Okay, so those are those two trials. I'm not going to talk about the anti-PD-1 trial, but that was approved in China and does have benefit. I'm going to now focus on the question of how can we improve long-term outcomes for more patients. So one approach is to use active agents. We know they're active for small cell lung cancer. Let's use them earlier. Let's use them in limited stage or in the front line or in the maintenance setting. And I'll talk about the IMforte trial. And then another approach is to optimize frontline therapy with combinations, either adding new agents to the frontline standard of care or replacing some of those components with alternatives. And I'm going to talk about that. Most importantly, I think we really need to seek to understand heterogeneity and the determinants of response and resistance for small cell to identify therapeutic vulnerabilities. And that's what the last half of the talk will be. And finally, I'll mention something that we can do to improve support of our patients throughout their journey. Okay, so lurbinectedin is one of the 3 approved second-line treatments for small cell lung cancer. So we know it's an active agent. It's a selective inhibitor of oncogenic transcription. It induces DNA double-stranded breaks, leading to apoptosis. And this was approved on the basis of a very small, open-label, single-arm phase 2 trial, 105 patients that showed an overall response rate of 35%. And that received accelerated approval in June of 2020. So the bar was pretty low, and it's still pretty low. So the IMforte trial takes an active agent, that's Lurbi, I'm going to call it, and basically adds it to maintenance. So in this case, you start out with patients, and they started out with 660 patients that were diagnosed with extensive stage. They got induction therapy, that's the chemo plus IO. And then if they had a response or stable disease, and if they had good performance status still of 0 to 1, they were then randomized to Lurbi plus atezo versus atezo alone until progression. Okay, and the first thing I'll note is that there was about 25% attrition from the patients who started the trial to those that they're randomized. So this is, again, supports this idea of using your active treatments earlier. I will also note that this trial did not include any patients with brain mets. Lurbinectedin is not an agent that's active in the CNS, doesn't really pass the blood-brain barrier. Okay, so this was a positive trial, and basically the overall survival from time of randomization to maintenance in the maintenance phase was 13.2 months in the Lurbi plus atezo arm versus 10 months in the atezo arm. So positive trial with 3-month overall survival benefit. And this was also then approved by the FDA in October of 25. So I think this is a great option for your patients that are fit, that have no brain mets, who have responded to frontline therapy. But there are some questions about this trial, and one of them is, none of the patients, there was no crossover allowed, and so very few of the patients who were in the placebo arm got access to lurbinectedin, even as second line. So the question here is, maybe this doesn't really tell us whether or not if you wait to give the lurbinectedin when the patient progresses, or if you do it upfront during maintenance, which is better. And the question there is, are we simply just moving up treatment of our cytotoxic second line therapy? The downside of that is our patients lose that window to recover from their initial therapy. And like my patient who was 3 years on just atezo alone, doing very well with very few side effects, we're actually adding chemotherapy to that in this trial. So I think it's important that this is a positive trial, certainly a good option, but stay tuned for other maintenance approaches. And I'm going to talk a little bit about some of the phase 1 data for tarlatamab. Okay, so let's shift gears and talk about targeting the immune desert in small cell lung cancer. So on the left, this is quantitative immunofluorescence done in Kurt Schalper's lab on a baseline small cell tumor. And then you can see that the DAPI is blue, so you can see the tumor cells. CD8 is in pink, so you see a few of those, but not very many. CD4 is in yellow, and you don't see many of those at all. FOXP3 is white. That's a marker of Tregs. On the right side, this particular patient has a week 4 biopsy after 2 doses of ipi-nivo, so anti-CTLA4 and anti-PD-1 treatment. And now you can see there's tons of T cells there. There's lots of CD8 pink cells, CD4 yellow cells, and you also have FOXP3 white cells there. So at baseline, there are not very many tumor infiltrating lymphocytes there, right? So how can we fix that? And one way we can do that is to use what's called a BiTE therapy. In this case, is a drug called tarlatamab. It's a bispecific T cell engager, and it has a binding specificity for DLL3, and that is on the surface of the tumor cell here. And it also has binding specificity for CD3, which is on the surface of the T cell, right? So now you're taking the T cells and bridging directly to the tumor. And that's designed to induce T cell proliferation, activation, and then lysis of tumor cells, apoptosis, and cell death. And I like to tell my patients, this is great because there's no chemotherapy involved in this, right? Okay, so does this work? Well, this is the phase 1 Delphi 301 trial, which we had open here. And the baseline characteristics of this trial, I want to point out, is that these were heavily pretreated patients, okay? So 65% of the patients had 2 prior lines of therapy. About a third had 3 or greater lines of therapy. Almost 70 to 80% had already been exposed to anti-PD-L1 or anti-PD-1 treatment. So heavily pretreated, these were getting tarlatamab in at least the 3rd line setting. Okay, so in this column, I'm going to focus on the 10 milligram dose, which was ultimately the dose that was approved. And the objective response rate, that means how many patients had partial response or shrinkage of their tumor or complete response, was 40%. And then an additional 30% had stable disease. So the disease control rate in this population of heavily pretreated patients was 70%. And so that merited FDA accelerated approval to tarlatamab in May of 24, and they actually approved it also for second-line patients, even though there were no second-line patients in this trial, right? And so we were waiting for the results of the randomized controlled phase 3 Delphi 304 study, which took patients who had progressed after first-line therapy and then randomized them to tarlatamab versus chemotherapy, gold standard phase 3. Primary endpoint, overall survival. The chemotherapy in this case was investigator's choice. And here in the left panel is the median overall survival. It's a benefit of 13.6 versus 8.3 months, so 5-month overall survival benefit, hazard ratio 0.6. PFS also positive. So this was approved, where it was already approved, but it affirmed tarlatamab as standard of care for second-line treatment, and really represented a new paradigm of using BiTEs for solid tumors, in this case, small cell lung cancer. Okay, how was it tolerated? Well, actually pretty well. The grade 3 and above treatment-related adverse events in the tarla arm was about 30% versus 60% for chemo. Treatment-related adverse events leading to dose reduction or interruption was 19% for Tarla versus 55 for chemo, and there are about 3 to 6% leading to discontinuation. So pretty well tolerated. But it has very different side effect profile. And you can imagine because we're activating the immune system, right? So one of the side effects you see with this drug is cytokine release syndrome. You have this systemic inflammatory syndrome. You can have fever, aches, pains, chills, hypoxia, hypotension, and that typically happens within hours after the first two doses. The way that we give this drug is week 1 at a low dose, 1 milligram, and then we step up the dose week 2 with 10 milligrams. And the FDA recommends observation for 22 hours after the infusion. So we admit those patients typically. So in the first trial, we had a cohort open here, which allowed us to treat about 30 patients in the outpatient setting. So instead of admitting them overnight for observation, we monitored them for 6 to 8 hours in the clinic, had them come back the next day. And what this showed is actually the CRS incident and time to resolution were pretty similar between the inpatient and outpatient groups. And this actually set the stage for doing the same cohort in the Delphi phase 3 trial that I just showed you, 304, and also showing that was a possibility. Here in green, you can see that 60% or so of the patients do have CRS, mostly grade 1 and grade 2, only 1% grade 3. The other side effect, which I'm not going to talk about today, is called ICANS in red. That's immune cell-associated neurotoxicity syndrome, can manifest as lethargy or confusion, and can also progress. But that was largely overall 6% only, and mostly grade 1 and grade 2. These are treated with steroids, and then for the CRS, also managed by tocilizumab. We participated in those early trials. We also opened an expanded access trial when the drug was approved. And this is a poster by Yunan Ni, one of the fellows that I've worked with, also Xiao Wang, who's in the audience, and Darren Luan, who's in pharmacy. And we described our single institution experience of 25 patients. Now we're up to 40. And this area down here shows you that we are working on an outpatient, a pilot program for outpatient administration for selected patients. And we just had that kickoff last month with one patient treated successfully. You have to be very careful with this because if you don't, they're very highly selected patients. So. But we are also participating in a consortium of about 11 to 12 other academic institutions in real-world data collection. It's a consortium called Onward, which I helped define, and now we have up to about 300 patients, and we're looking to see answer different questions regarding the real-world use of tarlatamab. Okay, so that's using BiTEs to target tumors. Let's now talk about antibody drug conjugates to target tumors. And here's your basic structure of the ADC, antibody drug conjugate. You have it recognizes a surface it recognizes a protein on the surface of the tumor cell, and it also has molecules of chemotherapy. These are the payloads, 4 in this case, attached to the antibody via a linker. And the way that it works is that the antibody recognizes the protein on the surface of the cancer cell. It's endocytosed. In the lysozyme, the enzymes degrade the linker and releases the payload or the chemotherapy, which then causes DNA damage or microtubule, prevents microtubule assembly, et cetera, and ultimately leads to the death of the cell. There are a fair number of these for small cell, and they're all super interesting. And this They're targeting different proteins on the surface of the cancer cell, CES6, B7H3, TROP2, DLL3. We've had trials utilizing all of these at Yale, and they're very exciting. Across the board, you see somewhere around 50 to 80% response rate, and there's differences in the payloads. They're mostly topo 1 inhibitors. There's differences in the DAR or drug to antibody ratio. Some of them have 8 molecules on one antibody, some have less, and there's differences in the linker. I am going to talk about one, not because it's particularly better, but just because I'm just going to talk about one of them. This is the CES6 antibody. So this particular antibody drug conjugate, this is work, a trial that we participated, presented by Lauren Byers at World Lung, and I've highlighted in the box the overall response rate. So 50 to 60%. If you had one prior line of treatment, it was the response rate went up to 70 to 80%. This included patients with brain mets. And I should say that the B7H3 does show intracranial efficacy in patients that have untreated brain mets. So these are really exciting drugs for our patients. But because this has such high response rate, almost equal to our response rates of 60 to 80% for frontline chemo, there is a new approach here, which is a phase 2 trial. It's called CES-AN. It's not named after me, but I do like the name of it and have been involved with the development. And this randomizes frontline patients to this antibody drug conjugate plus immunotherapy. So this is a platinum-free agent. I've said multiple times that platinum doublet is our gold standard. Now we're going to replace that and compare it to the gold standard platinum doublet immunotherapy. Again, changing a massive paradigm. So we actually just had the SIV for that trial at 11 o'clock. It's a busy day today, so we'll see how that goes. These are some of the other really exciting first-line or maintenance trials. Not going to go over all of them, but in red, you can see that we're adding active agents, either tarlatamab in the maintenance or tarlatamab in the frontline. We have both of those trials open here. Or a tegotatug. That's an antifucosyl GM1 antibody. So this is now starting to look at, can we do both dual innate immunity plus the T cell response? In blue, these are first-line trials that replace components of the frontline regimen. The one in the bottom replacing the platinum doublet with ADC, that's the CES-AN trial. And the other ones are replacing the immunotherapy anti-PD-L1 with a bispecific anti-PD-1 and VEGF antibody. So super exciting times right now. So that maintenance one, that one finished accrual so quickly. It's going to report out, I think, within the next year and a half to 2 years. Why are we so excited about that? Well, look at this phase 1 data. All right, so this is Kelly Paulson's data. She presented at World Lung, now it's in Lancet. And so she took patients who had gotten induction chemo IO, and then there are about 88 patients, and they got Tarla plus immunotherapy, either Durva or Etizo. And look at that median overall survival, 25.3 months. Now, I just told you about the Inforte trial with lurbinectedin that had an overall survival from time of randomization of 13 months. So this is an active agent. I think this is really going to change the paradigm of how we do our frontline and maintenance treatments. Unfortunately, not all patients do respond to tarlatamab. And I had a patient last week that had progression. And so one of the questions we're going to have to really address is, what are mechanisms of resistance to tarlatamab? And this shows you, courtesy of Dr. Guoping Kai, a collaborator, DLL3 staining in patients at time of progression. So here on the right side, this is my patient, her adrenal pretreatment, H&E staining, and here's the DLL3 staining, very robust, probably around 70%. And then this patient was on tarlatamab for over a year, almost 15 months, and she did have oligoprogression in the adrenal. And so that adrenal we actually took out and we stained it at time of progression here. And she's got a lot of tumor there, but you can see that the DLL3 staining is much, much less. I think around 20%. So, is target downregulation a mechanism of resistance? And actually, we saw the same thing. This is a patient of Dan Petrolak's. It's a patient with neuroendocrine tumor that transformed to small cell from adenocarcinoma. And again, here's the pretreatment H&E staining and DLL3 staining, very robust. And the patient initially responded to tarlatamab, but then progressed. And a biopsy at that time shows you much, much less, about 30% DLL3 staining. So there is a project that Kurt Schalper and I are collaborating on to look at tissue microarrays as well as different proteins on the surface of the tumor cells after treatment with progression biopsies to look at mechanisms of resistance. Okay, so the key points in this first more clinically based part of the talk are here. So immunotherapy is here to stay for extensive stage and limited stage, both. We have secured full FDA approval for tarlatamab for second line with that phase 3 randomized trial. There are new approaches moving active agents into earlier settings, for example, lurbinectedin in maintenance, that's the IMforte trial. Stay tuned for other clinical trials in the maintenance setting, including the randomized phase 3 with tarlatamab and a biomarker trial that I'm going to tell you about momentarily. And then I like food analogies. So this is my plate of cookies, right? And this is just to remind us that I think small cell is a lot more complicated than just one black and white cookie that's limited versus extensive stage using platinum doublet with or without radiation and immunotherapy. I think it's a whole lot of different kinds of cookies. And I think that by understanding that, that will lead the way to more effective and targeted treatments. But in order to do this, we have to have adequate tumor biopsies, and we need to utilize our translational clinical trials. Okay, so the targeted approaches. On the bottom, we've already talked about the ones that target surface proteins, DLL3, our BiTEs, our antibody drug conjugates. Now we're going to talk about how to target subtypes of small cell. And we're going to talk about different subtypes such as A, N, P, and I, and also utilizing Schlafen 11. Schlafen 11 is, as many of you may know, is a critical determinant of sensitivity to DNA damage agents. It binds the replication fork and it blocks it. It opens the chromatin and it's basically an irreversible block of replication and leads to cell death. So, I think there are some vulnerabilities there that we can take advantage of. Okay, so let's talk about subtypes. So Carl Gay and Lauren Byers are collaborators from MD Anderson, and they did this work using the Empower 133 trial. And that is, as we talked about, so basically they did unsupervised clustering of the 276 patients on that trial, and they came up with 4 subtypes. And 3 of the subtypes were characterized by overexpression of certain transcriptional activators. So this subtype here was subtype N, has overexpression of NeuroD1. Subtype A has overexpression of the ASCL1 transcriptional activator, and subtype P overexpresses POU2F3. A and N are what we call neuroendocrine subtypes. Now, the other subtype, in this case termed subtype I, is kind of a triple negative. It doesn't have overexpression of any of the 3 transcriptional activators that I just talked about. And it does have, however, activation of immune genes such as interferon gamma, the STING pathway, immune checkpoints, and HLAs. So it's sort of an inflammatory signature. And so when they looked at the patients in this trial, according to subtype, what they found is that those subtype I patients had the best overall survival, 18.2 months in the platinum doublet plus atezo arm, so with immunotherapy. And if you remove the immunotherapy, so the placebo arm, that effect went away. So that the overall survival was then 10 months. So their thinking was that, okay, subtype I is a biomarker of, of benefit from immunotherapy in those patients. So, are there ways that we can target other subtypes and their vulnerabilities? Well, this is again work from Carl. Let's talk about subtype P. And in this panel, it shows that the P models that he had showed exquisite sensitivity to PARP inhibitors, and that was independent of Schlafen 11 status. The neuroendocrine subtypes A and N were sensitive to PARP inhibitors, but only if Schlafen 11 was positive. Here you can see olaparib, Schlafen 11 high, and then in olaparib, the IC50 for Schlafen 11 low. And then in for those neuroendocrine A and N subtypes, in Schlafen 11 negative models, the loss of ATR was synthetically lethal. Okay. What about the I subtype? Was there something else about that that could be targeted? Well, in the I subtype, there are more NK cells, and they also found that the NKG2A ligand, HLA-E, was highest in this subtype. So putting this all together, but understanding that we have to have a test to show what subtype they are, they worked with a company called Boston Gene, and there's Carl and Lauren, and they validated the Boston Gene test with their data and found that you could actually have quite a nice classifier, and here's the report over here, that would tell you what subtype the patient has. Here it's subtype P, and that this could be done with relatively small amounts of tissue, and the turnaround time was quite fast, right around 10 days. So putting this together, we worked together to create a cooperative group trial through SWOG called the S2409 PRISM trial. And this is a busy slide, but just basically the bottom line here is that in step one, when the patients are getting induction chemotherapy plus IO, there's over 800 patients that we're going to collect tissue from to see what subtype they have and what the Schlafen 11 status is. And then based on that biomarker, they will be randomized to the agent that targets that subtype. So in this situation for the neuroendocrine subtypes A and Schlafen 11 positive and subtype P, they'll be randomized to saruparib, a PARP inhibitor, plus durva versus durva alone. In the subtype I, they'll be randomized to monalizumab, which is an NK cell activator, in addition to durvalumab versus durvalumab alone. And in cohort B, which was A and N positive, Schlafen 11 negative, we were going to have them randomized to an ATR inhibitor plus durvalumab versus durvalumab alone. But unfortunately, just as of 2 weeks ago, that drug is not going to go forward. So we're going to figure out a different solution for our cohort B patients. But this just opened nationally. We have about 300 sites right now so far. Just opened a month and a half ago, and we have, I think, 20 patients already, and they're coming in. So we're really excited about hope, but how to prepare for the future. And so the bottom line here is to to try to use the mouse. Talk about expectations and prognosis. Okay, acknowledgments to the thoracic team. This couldn't do this work without the group that of and the village that really works together, makes it fun, makes it doable. All of my colleagues within the clinical team and the research team. A lot of the work that I presented is work that Yunnan Ni really championed, as well as Rob Matera when he was a fellow. Really need to thank my scientific collaborators, in particular, Kurt Schalper and the people in his lab, Katie Arnaud and Guoping, and outside Yale, Carl Gay, Lauren Byers, and some of the other folks that I've worked with. And then finally, always to our patients and their families. They really are the North Star for the work that we do. Thank you.
All right. Thank you for that amazing talk. Questions? I'm going to get started with a question. So my question was about the DLL3, where you showed the example from Dan Petrolak's patient. And so you kind of know where that is heading. So how broadly effective is tarlatamab in neuroendocrine tumors? And yeah, so how's that working? Is that something that we should be thinking about more? Some of these strategies, can you expand them to other neuroendocrine tumors as well?
I think the answer is yes. I think it's still early. I know that there are and have been involved with some of the different pharma agents with different bispecifics that have shown utility in large cell neuroendocrine tumors, which often are very highly expressing DLL3. We have here at Yale, and we're working again within this Onward consortium to lead an effort to look at extrapulmonary small cell and neuroendocrine tumors. But we've seen some nice responses. Not always, I mean, I think DLL3 is something that that test has just been developed in a CLIA fashion, and so we're starting to use that on our patients. But I think anecdotally, definitely in some of the very early phase ones, we do see some nice expression in like 10 patients and some responses there. So I think it's a very exciting time.
Thank you. Are there other questions?
Great talk. Love all the shout outs and wonderful collaborations. To follow up on Katie's question a little bit, actually, I was noting how little plasticity actually in terms of the subtypes of small cell there seemed to be, and kind of curious. And one of the maybe differences in prostate cancer or NEPC is that you perhaps have more plasticity. And so I was curious if you saw maybe more plasticity in later lines after initial therapy with small cell lung cancer, or if you had any insights about that as a kind of defining feature of response.
That's a great question. I mean, I think in the literature there is very little data, but there are some examples of plasticity where there have been some changes. In our hands, we did not see it. I, you know, whenever you're targeting subtypes, and this was one of the questions for our trial, how are you if it's going to be changing, then how are you really, is that a great biomarker? But I think we don't know yet. And I think these are all questions that remain. We do have that case study on those two patients with prostate neuroendocrine. Kurt, you are also an author on that case study that we're going to send in soon.
Fascinating. By the way, Happy New Year.
Happy New Year.
And the question I'm asking is is there any relationship of biomarker in cytokine chemokine profile in the plasma sample versus the tissue sample?
That's a great question. And I don't know yet. I have all the, we have all the blood samples collected and just waiting for a funding mechanism to figure out how to.
If you don't have anybody, we will be happy to uh, help you in assessing
Fantastic. I'm
many
going to
of
follow up with.
cytokine, chemokine in the plasma.
Yeah.
I think if you can do plasma instead of a tissue, that'd be even better.
It's certainly more available for
Yeah.
sure.
Another is what's any idea the interplay between inflammatory process and the immuno process, T cell response in those patients?
Another great question that I don't have an answer to, but certainly something that we'd like to be studying. Yeah.
Thank you. Rob, you had a question?
You
You get the last question.
As long as we're not going to biopsy, we're going to go to a blood peripheral vein. I'm going to go even one further, talk about imaging correlates, whether there's any advanced imaging techniques that would substitute for some of these markers as well, like a DLL nuclear medicine scan.
Yeah. Yeah, absolutely. That's a great question. And there are, I didn't talk about this time, but there are radio pharmaceuticals based on DLL3 and other proteins that are being developed. And I think those are exciting to look out for.
Okay, I'm going to ask a question. What's going to be better, the DLL3 BiTE or the DLL3 ADC?
Well, I think they're going to both be used. The DLL3 BiTE doesn't have chemo, and so I think for patients, there are side effects, including dysgeusia, which can really affect a patient. That's lack of appetite, lack of taste. But I think that we're going to need to use them in sequence for different reasons. I think that the ADCs may be more effective initially in terms of cytoreduction, and maybe that will replace platinum doublet and be combined with a BiTE in the first line. So I think we're going to need most or need both. But I of course am very excited about the BiTEs because we're going beyond chemotherapy. Thank you.
Thank you. Thank you very much for that amazing